Thank you, Christian, for this introduction. Dear Chair, dear colleagues, as we've just heard now from my colleague Miriam, and also yesterday from our industry partner, perioperative complications are an emerging topic, and as there has been growing evidence that perioperative cardiac complications are frequent and are associated with high, short, and long-term morbidity and mortality. Actually, there has been a study published in Lancet in 2019 that showed that postoperative deaths is among the leading causes of deaths worldwide. And as we also heard before already, the detection of perioperative complication poses specific challenges as symptoms are often marked and therefore overlooked if there's no targeted surveillance. So therefore, we have the new 2022 ESC guidelines on the management of patients undergoing non-cardiac surgery, and they now recommend with a class 1 perioperative biomarker screening for early detection of perioperative complications. So now we have identified the big problem, but there is an even bigger problem because evidence on how to improve the outcomes of this patient group is scarce. So there was one trial, the MANAGE trial, that showed that dabigatran twice daily lowered cardiovascular complications in patients suffering from myocardial injury after non-cardiac surgery due to ischemic cause. However, as we gained more knowledge about PMI, we know more and more that PMI is a very heterogeneous disease with various underlying pathophysiologies such as type 1 or type 2 myocardial infarction, acute heart failure, or also extracardiac causes such as sepsis. And the identification of the most possible pathophysiology is crucial for the selection of the most appropriate therapy. So within the last 10 years, we have built one of the largest and best described cohort of patients undergoing major non-cardiac surgery. And these eligible patients participated in the PMI surveillance and response program. As you've heard, they received the perioperative biomarker screening. And then in case of a PMI, the structured institutional response included the assessment for possible PMI symptoms and the recording of a 12-lead ECG. In addition, a cardiac consultation was triggered. And then the scope and the sequence of the cardiac workup was defined by the treating cardiologist. So for this analysis, we wanted to evaluate the association between cardiac consultation and major adverse cardiac events and all-cause death within 1 year. MACE was here defined as a composite of cardiovascular death, MI, acute heart failure, and life-threatening arrhythmia. We then used Cox proportional hazard models to evaluate the association between cardiac consultation and our outcomes. So moving on to the results, we had a total of 1,875 PMIs from a total of 14,300 screened surgeries. We then further excluded patients with a postoperative ICU stay and patients with multiple PMIs within 1 year. This left us with a cohort of 1,060 PMIs, and 58% of the patients received postoperative cardiac consultation. Here you can see a small table of some baseline characteristics of the cohort. The median age was 77 years, and 55% of the patients were female. And as you can see, the history of different cardiovascular disease was evenly distributed between the two groups. In total, 16% of patients suffered from a MACE within 1 year. And here you can see the result of the Cox model with an adjusted hazard ratio of 0.56. So we can say that cardiac consultation was associated with a 44% reduction in MACE after 1 year. Here you can see conditional effects plot of 3 patient examples with a low-risk patient to see a high-risk patient. And on the y-axis, you see the probability of being free of MACE, and on the x-axis, you see time. In dark blue are patients that receive postoperative cardiac consultation, and in lighter blue, patients that did not. And as you can see, among all the levels of patient risk, we see that patients that receive postoperative cardiac consultation had less MACE after 1 year. And another observation is that the higher the risk of the patient is, the more pronounced this difference between the two groups gets. So moving on to the secondary endpoint, all-cause death, 13% of patients died within 1 year after their surgery, and the Cox model showed here an adjusted hazard ratio of 0.7, so cardiac consultation was associated with a 30% risk reduction. So now, to finish, I want to show you this table, 2 examples of postoperative cardiac diagnostics in relation to the recommendations from the cardiac consultation. So first, we see that patients that receive postoperative cardiac consultation had, in general, more postoperative cardiac diagnostics performed. Now, when we look at the recommendations from the cardiac consultation and how they were adhered to, we see some differences. For example, recommendations to perform an echocardiogram during the index hospitalization was followed in 70% of the cases. However, recommendation to perform a myocardial perfusion imaging, mostly in an outpatient setting, was not followed as well. Of course, there are some limitations that merit consideration. First, even though we provided an outline for the cardiac workup, in the end, this was defined by the cardiologist in charge. Also, adherence to the implementation of the recommendations by the cardiologist cannot be completely followed up. So I would like to summarize. Patients with PMI receiving postoperative cardiac consultation with further cardiac workup had less MACE and lower mortality within 1 year after undergoing major non-cardiac surgery. Thank you for your attention.
So Noemi, this was outstanding. For those of you who were impressed by Noemi on stage, we will be even more impressed tomorrow morning seeing her on the football field. So coming back to the topic, could you perhaps describe in more detail why within this active surveillance program not everybody has received a cardiac consultation? I think that's important to understand why there were 2 groups.
Of course. So reasons for patients to not receive a cardiac consultation were mostly, I think, about half of the patients that did not receive a cardiac consultation, it was due to this PMI happening on the weekend. And we defined in the beginning that due to, of course, some shortages in staffing, that we will take a different delta on the weekends to trigger a cardiac consultation, so it was not the normal 14 nanograms per liter that was used during the week, but it was a delta of 50 nanograms per liter. So that's one reason. And then another reason was also that we defined in the beginning that if there are other more urgent patients that need to be seen, the cardiologist in charge can decide to not go to the patients that suffer from a PMI. These are the 2 most common reasons why the patients did not receive cardiac consultation.
I have a follow-up question. It's really interesting data, and the first time I've seen data from the implementation of one of these programs, so it's fascinating. I think your adherence is pretty good considering actually these are complex patients, there's a lot going on, a lot to think about beyond cardiac investigations, but of course an echocardiogram and a myocardial perfusion scan does not improve survival or reduce MACE. So what treatment differences were there between the 2 groups that might plausibly have influenced these outcomes, because the potential for bias within the selection of patients for consultation is quite high. So can you explain what you think the mechanism of improved outcomes is?
I mean, of course, that is the million-dollar question, and I think I cannot answer it fully so far, but what I believe is that it's like just the whole bundle of care that improves the outcome, and especially that a cardiologist was involved in the postoperative care of this patient, and the cardiologist went to see this patient clinically with that there was even a possibility to intervene if there was something really amiss with this patient.
If there are no other questions, thank you very much. I like the concluding remark there.